think this academic year's first journal club. I'd like to introduce and thank Dr. Cates for coming in. He's one of the internal medicine staff, and he's the head of the research and development department here at Henry Ford. So let's go into it. There's a lot of content to cover. So I have no disclosures. A little bit of overview about what I'm going to talk about. A little bit of introduction. I sent out already the article, so we're mostly going to, our main focus is kind of talk about systemic reviews and meta-analysis. We're going to do some article discussions after that as well, and then end up with the conclusion. So this is a study that I picked. It's an article that was published back in 2015 August, if I'm not mistaken, in the Annals of Internal Medicine. It's basically looking at steroids and in treatments of pneumonia, and I think that's something that was intriguing when I saw it, which is why I picked this article. And the reason why I picked it is I wanted something recent, so it just came out not too long ago in 2015. Well, I think it was a good opportunity to sit down and kind of talk about systemic reviews and meta-analysis. And also I wanted to kind of, when you guys leave the room, to maybe think about it more and maybe even change the practice. So a little bit of introduction. I'm talking a little bit about sepsis, and Dr. Rivers can kind of chime in if I say anything incorrectly. But what happens usually, especially in pneumonia, what you have is that organism invade the alveoli. First thing you have is the alveolar macrophages that goes in and try to phagocytosis that those molecular or invading organisms. What eventually happens when the infection is overwhelming is you get neutrophils that come in and do kind of the same thing. And this kind of promotes a more of an inflammatory cascade. You've got activation of the complement system, you've got and the coagulation system, either directly or indirectly leading to DIC. What you also have is that more of a cytokines, including interleukins 1s, interleukin 6, 18, and TNF alphas that come in, and those are usually more protective. But when you have a significant inflammatory response, what you can have is something called a cytokine storm, which can increase inflammation, cause apoptosis, decrease immunodeficiency, and lead to worsening sepsis. So the thought of using steroids, came back. This is an old article. It's not really a well article, but I think it's just a proof of concept. Where it was done back in 1999, and they did 20 patients, and they had a group that were, patients who were on admitted for pneumonia, community-acquired pneumonia. About 11 of them were on steroids, and 9 of them were not. And what they did is they got serum and BAL samples a few days after their initial admission, and a few days later. And what they found is that when you compare the two groups, you'll find that there's a decrease in the cytokines that I mentioned before, including interleukin 1, 6, and TNF alpha. So that's kind of where the concept comes in using steroids in pneumonia. So again, I'm talking about systemic review. So what is a systemic review? It's basically a comprehensive analysis looking at all the studies that are out there, focused on a very specific question. And the reason, and what they do is they appraise the studies, summarize the results, present the key findings, identify reasons for differences between results, and then cite their limitations. And the reason why we do systemic reviews is just to kind of limit bias in identifying those studies, evaluating them, and synthesizing a hypothesis from them. And that's kind of a difference between narrative review. Narrative review is like someone like me. I've done 6 weeks of transplant right now. I've read a few studies out there. I'm like, okay, I'm going to write a review about something about transplant. Obviously, I'll have my biases. I don't have that much experiences. It's just not an accurate way of actually. I probably will be very biased, and that's where systemic review comes in. It comes in with a very focused clinical question, a very comprehensive search on the studies that are out there. That has a very specific selection criteria. They do a rigorous appraisal of the studies, and then they synthesize quantitatively the data, and it's mostly very evidence-based. And then there's also meta-analysis. So meta-analysis is usually a subset of systemic reviews. And what they do is basically combine all the quantitative data that we have from all those studies to develop a single conclusion with greater statistical power. So you'll see some systemic reviews out there without meta-analysis, but most meta-analysis usually have a systemic review with it too. So just keep that in mind. And usually systemic reviews and meta-analysis are really up there in terms of quality of evidence-based medicine, especially when done correctly. And that's what we're going to be talking about today. So just briefly, I want to talk about the inclusion criteria of our study. It basically included only randomized controlled trials that looked at patients with community-acquired pneumonia versus oral or intravenous corticosteroids, and comparing that to placebo or no treatment. The duration and dose were not specified. Exclusions were ventilator-associated pneumonia, aspiration pneumonia, PCP, and studies that limited to patients with chronic obstructive pulmonary disease. The outcomes that you look at were, the study should have at least one of these outcomes. Looked at mortality, hospitalization, time to clinical stability, which means when their vital signs have normalized and they've been on room air, need for mechanical ventilation, need for ICU admission, and the development of ARDS. The harm, in terms of harm, the outcomes that they were looking into were rehospitalization, hyperglycemia, GI bleeds, and neuropsychiatric symptoms such as delirium, psychosis, and so on and so forth. So we're going to do this a little bit differently, I thought. So I think the best way to do it, we thought about doing it, is starting by talking about the results first, and then going on a discussion. So what I'm going to present right now are the results of the study. So in terms of mortality, what they found, so this is what we call the forest plot. So you'll see on the left-hand side all the studies that are included in in looking at mortality, and there are 12 studies. Here they were split into patients with severe pneumonia versus less severe pneumonia. And then you'll have all the study results here on the right-hand side. So you'll, those squares in the middle are usually the relative risk or hazard ratio, odds ratio, whatever the studies used. And then of course the two lines here would be usually the confidence interval. And what you'll have here at the end is a total, which is what you'll find in the meta-analysis, where the middle right here would be the relative risk in this case, and the two bars here on the side would be the confidence intervals. So in terms of the results here, what we find in terms of mortality, that there's no mortality difference in patients with pneumonia. So you can see that the line crosses 1 here, so there might be a trend towards decreased mortality, but it really is not that statistically significant. Yet, if we do a subgroup analysis that they did and looked at patients with severe pneumonia, and by severe I mean patients with a PASI score of grade 4 or 5, CURB 65 of 2 or above, and an IDSA criteria, which was published in 2007, that had I think 1 major and 2 minors. So basically, that's where the definition of severe pneumonia. And in that population, you can see that there is decrease in the relative risk, so it's 0.39, and that was statistically significant based on that study, or based on that meta-analysis. Where looking at patients with severe pneumonia, there isn't much of a difference. So trend is towards improved mortality in patients with severe pneumonia. All right, what about duration of hospitalization? So again, they split them into a low risk group. So there's only 3 studies that had low risk of bias and high risk of bias, which are about 6 studies right there. In total, there was a decrease in hospitalization by about 3 days, which was statistically significant based on what they were saying. But when you look at patients or in the low risk or low bias studies, which was only 3, there was a decrease in hospitalization by 1 day on average. And then the highest, on the high risk of bias studies, there was a decrease about 0.4. All right. Any questions so far?
Yeah, can we go back a slide? I might take a different view. I'd be interested with some of the other faculty. If we go to the very bottom, so the relative risk is 0.67, which means that there is a 33% relative risk reduction. So we're saying that we're decreasing mortality by about a third. I read the confidence intervals is that our best guess is we lower it by a third, but we might lower it by as much as 55%, the 0.45 relative risk, or we might increase mortality by 1%. And to me, when we're talking about mortality in a very common disease, I might swing towards not saying that it doesn't decrease mortality, because there's nothing magic about the p-value of 0.05. It's just by convention. There's nothing magic that we have to use 95% confidence intervals. To me, this paper gets my attention, and I'm willing to roll the dice, if you will, and say, I'm probably decreasing mortality, and the worst I am is that I got only a 1% relative increase in mortality.
I think you're right, and I think we get too wedded to the idea of looking at specific to 95% confidence interval or the p-value of 0.05 instead of actually looking at what the data shows. And that's a really good example of how, maybe steroids is a good idea if you've got a disease where this high risk is on, right? So, yeah, I agree.
Yeah.
All right, so now we move on to, we talked about duration of hospitalization. Mechanical ventilation. So again, they split the groups into severe pneumonia and less severe pneumonia, and they were found in both groups that there was a decrease in risk of being on mechanical ventilator in both groups. Though in the patient with less severe pneumonia, actually the percentage is actually higher, so the relative risk was only 0.18 with a higher confidence interval, and that's based on just 2 studies compared to 3 in the severe pneumonia. When it comes to need for ICU transfers, again, only 3 studies looked into that, so only 3 studies had that as an outcome, and if again, the relative risk was 0.69, so 31% decrease in ICU risk, but or ICU transfers. But again, in terms of the confidence intervals, it does cross 1, and the highest it can be 1.03 right there. When talking about time to clinical stability, and as I mentioned, clinical stability means normalization of vital signs and being on room air. There's also a decrease based on 5 studies they looked at in terms of time of clinical stability by about an average of 1 day. And again, the confidence intervals kind of are less than 1 in here. Or less than 0, I should say, because these are in days, so less than 0. All right, and in terms of ARDS, again, 4 studies that looked into it, and it shows that there is a decreased relative risk in terms of development of ARDS based on 4 studies up there. Okay. Adverse effects, the only thing that came back positive or significant, and which is what I added, was the use of hyperglycemia. So again, there was an increased risk in most studies, and this included 6 studies, showed that the relative risk increased by 1.49, and again, confidence interval was above 1. All right, so those are the results. So in summary, what this article is saying is that patients with severe pneumonia have a decreased mortality rate, so there's an argument of using steroids in that population. There's a decrease in hospitality by 1 day, and thus based on low bias risk studies, which were 3. Decrease in risk of mechanical ventilation, time to clinical stability, and ARDS. But having said that, there is an increased risk of hyperglycemia. So that's kind of the summary of the results that's being projected to us. So that's it. I'm done. You guys are good. All right. So what we're trying to do. So what we're trying to do is rather than just me coming up with talking about the journal, I wanted to make this more of a discussion. So I presented to you guys all the results right now, and so as I mentioned, are you guys going to just walk out of the room and just start prescribing steroids for pneumonia, or you guys want to have more questions about this article that you want to raise up about how it's done, why it's done, and more of the methods that it's been conducted? Anything that you guys want to know about this study? Yeah, so that's a good question. So as I mentioned, they did not, when they looked at the inclusion criteria in the research, they did not include any of that in terms of the dose, IV or oral, or the duration. So that's not really part of their in terms of analysis. So I think that's a very good point that you bring up in terms of before they included the article itself included 13 studies. But I think what we need to talk about when we look at meta-analysis is the search. What were they looking for? So that's a very important question, and that depends on their question and how broad they want to be. So I think that's a very good point that you bring up. So we can talk about that some more. All right.
Can I just make
Of
one
course.
comment? I think your question is really going to the clinical heterogeneity. So we talk a lot about the statistical heterogeneity, and we tend to look at those numbers and go, if it's low, that's fine. But the much bigger question, I think, is does it make sense to mix high-dose IV steroids with moderate-dose oral steroids? If that's what was used in the trials, does that even make clinical sense to pool those studies together? I think that's the hardest part of a systematic review is deciding, does it make sense to lump these studies together to do a pooled analysis?
And the problem is the clinical heterogeneity implies there's more to that term than just the dose or the regimen of steroids. There are some treatments that we use. For example, you could do something in the cancer ventilation where the treatment itself might, in some ways, for the population, might be homogeneous. If I'm thinking about 13 diverse studies on pneumonia, I want to know more than just about the regimen, which is a good question. But also, if these are from different regions of the world, you might be talking about different organisms. Depending on each study who they looked at, there may be different demographics and patient characteristics. And so this is a clinical problem for a meta-analysis. It's more troublesome than a lot of the others because it's not as straightforward for patients. It's not as straightforward treatment. We don't know what antibiotics they got. So the clinical heterogeneity in this group has multiple facets to it. Not just one thing.
And I think I cut it off because I think we do need that. I think I would add to that, obviously, the patients might have other diagnoses or with steroids that are treatable. COPD being the most obvious one. It would be a question that would come up. Could it be that the steroids are doing something unrelated to the gap?
That could be further, especially if you have studies that are temporal and far apart, like study in 95 or study in 2005. The standard of care may change. And, again, when you think of ventilator-based or mechanical ventilation, you can't help but wonder, well, did, the standard of how you deal with mechanical ventilation change over the time frame that these patients had these various studies? So that also, again, is a key factor.
For Geneva, that might have been tempered a little bit in this one because they only used randomized trials.
True.
So at least in 95, whatever the ventilator, and critical care processes were in 95 were still split evenly in the 90 studies versus the, more recent studies.
Are you going to talk about heterogeneity?
Yeah, so I think that's one of the main topics when you look at meta-analysis systemic review. So when you're pooling all these studies together, does it make sense pooling them? And that's when heterogeneity comes in. So I think a good meta-analysis does talk about heterogeneity or looks for it in terms of a study. So let's talk about that. All right, so heterogeneity. So again, as I mentioned, it's something that can occur with almost all systemic reviews, and if they want to see if there's any differences in the studies that are outside of realm of just chance. And there's different types of heterogeneity. There's clinical, where we look at maybe patients' populations, doses of medications, and the things that we talked about. We talked about methodology, if the statistical analysis are different from one study to study, and then, or again, talk about methodology in terms of how they perform the study, and statistical heterogeneity, which basically combines both clinical and methodological heterogeneity together. So again, as I mentioned, each study has to look at it, and they do some there's different ways to do heterogeneity. The way our study looks at it, and most of the meta-analysis that I've kind of looked at, does something called a chi-square, and includes it into their forest plot. And it's usually a statistical analysis, which I'm not going to really go into, but again, the goal of it is trying to see if there's any differences in the studies that is just outside of realm of chance. The power, I think, of heterogeneity, Dr. Case, from what I read, is actually not that great in heterogeneity, which is why the p-value is usually a little bit higher. It's 0.1 rather than 0.05 to determine statistical significance. And usually what happens is that if you have big group of studies, even small differences can lead to positive heterogeneity. So that you should keep that in mind as well.
Yeah, just the thing to remember, though, this doesn't get to your point. This is only looking at how diverse the results are, and because the the concept, that my understanding of the concept is that if the results are really scattered all over the place and aren't consistent, then you have to go back and ask yourself, are you mixing too many apples and oranges together, and it doesn't make sense to put all those in the same basket when you pool the results.
And again, I think the point, to me, the point about all of these kinds of tests, which is also very hard, is that you mentioned it with power. So any other test we look at, we're trying to prove that the p-value is less than something. For this, we're sort of happy when the p-value is greater than something. So the best way to get a high p-value is to include few studies, right? We know underpowered studies are always going to have low p-values, right? So if you're only comparing 3 studies, it's very unlikely, even if they are very different, you're very unlikely to get a p-value that's low that's going to raise your concern. So it's sort of the opposite of the way we normally think about it.
Which is now why we use the I-square, which I guess is your next slide.
Yes. All right. So how do you measure heterogeneity? So basically, there's something called the I-square, which is just gives you a percentage of differences between groups, and it's an equation. It's the chi-square minus the degree of freedom, which is the number of studies, over again the chi-square times 100, and it gives you just a percentage basically. And you know, basically from 0 to 25% low degree heterogeneity, 25 to 50 is moderate, 50 to 75 is substantial, and there's considerable heterogeneity with greater than 75. So that's something, that number or something you guys have to look into as well. And most studies out there, they usually include it on their forest plots.
Yeah. But it tells you how much variability in the results there is above and beyond chance. If you did the forest plot and every line was exactly lined up, you go, that doesn't make any sense, right? So you're going to see some variability by chance, and that's driven by the size of the trials and the width of the confidence intervals. This really measures how much there is above and beyond that. And if we get to substantial and considerable, then we have to go back and ask ourselves, did it make sense to mix different types of populations or different decades of ICU care or different types of steroid doses?
So, I mean, I've added just this one slide back to going back to the result in terms of duration of hospitalization. And what you'll see is that so they usually mention the heterogeneity or statistics right there, and it's usually always in the forest plots, and they mention them. And you can see when we talk about the duration of hospitalization, there was a great degree of heterogeneity between the groups. But then when they did the subgroup analysis, and again they split their studies into smaller groups, you can see that in the low risk bias studies, or let's talk about the high risk bias first. You see that the I2 is actually 88%, so there's considerable degree of heterogeneity between them. And I mean, just looking at it, you can actually guess that as well, just by looking at the...
Well, yeah, the two bottom studies also, they are not consistent with each other at all. The confidence intervals are extremely far apart from each other.
Yeah. And then we look at the low bias studies, which are only 3, you can see that the I2 is 0. Based on this, is fairly little degree of heterogeneity, statistically speaking. So is there any questions regarding that before we kind of move on?
So overall, in terms of all of the results you presented, what was your sense of the heterogeneity? Obviously, for length of stay, there's...
Yeah, so we can go back, and so let's go back. So usually, based on these studies, so the primary outcome, mortality, and all these things, the degree of heterogeneity based on this was actually was low. So it was and again, severe pneumonia. This is mortality is only 0. And less severe pneumonia was also 0 as well. And they found that it was the same in all of them. Obviously, the duration is the one that's different, which is why I brought it up, just to show a difference. But again, here, random effect of heterogeneity was 0%. Similar to ICU transfers, and similar to clinical. Well, actually, in the clinical stability, time to clinical stability is actually 38%.
Yeah, and the dots don't line up very well.
Yeah. All right. Talk about ARDS, the same thing as well, and adverse effects in terms of hyperglycemia. Okay. Okay, so we talked about, I think, a very important concept when it comes to reading these. Any other? I mean, I know PJ mentioned about differences within the studies and what were their selection criteria. I think that's very important when you read meta-analysis, how selective they were in terms of their search. I know people who've done meta-analysis. I'm sure they'll tell you that's probably one of the hardest things to do is kind of look into 4,000 studies and try to come up with the relative ones to your topic. So I guess we can take time to talk about that. And it's a very important question that when you read meta-analysis, is to ask yourself, is it unlikely the relevant studies were missed? So usually when you do meta-analysis, you go to the all medical article databases, including the most popular ones, Medline, MBAS, Cochrane, and Google Scholar. It's very important to also, when you're reading your studies, to even go over your reference list as well, because you can pick up studies from there too. Personal experts is very important because you can sometimes find out studies that are not out there you don't find, or studies that are ongoing that you might want to include later on. And of course conferences and abstracts and books as well. And the real goal is to kind of go drop or limit your publication bias, which I guess we can talk about later on even further. So what did our study do? So our study did something very interesting where they did something called a rapid meta-analysis, where they took basically what Cochrane did, because Cochrane actually did this systemic review back in 2011. So they took their search process, they looked at studies back 50 years from 2011, 50 to 60 years. They came up with 6 studies. So we're like, okay, Cochrane did a good job, so we'll just take their 6 studies and assume that all of those 60 years of data have been accounted for. And then what they did is that they did their own search, very similar to what Cochrane did at that time. They look at MBAS, Medline, Cochrane, the review, Google Scholar, and they also went over a reference list of the included studies and existing systemic reviews, and look over a period of 2010 to 2015. And what they did is that just based on the 5-year period, they got 4,000 studies. They excluded a lot of it just for relevance and duplicates. They included the 6 studies that were included in the Cochrane review, end up with 50. And then if you can see here from articles retrieved from references, they actually got 3 articles that were not included in their search. So it's very important to look at references when you're doing systemic reviews. Eventually they were able to exclude 44 for either not randomized, which is part of their inclusion criteria, not reporting outcome, duplicates, and so on and so forth, and came up with 13. So our meta-analysis systemic review included 13 studies, 4 from the old one and new studies that came out during the past 6 years or so.
Does that mean that they took
2 of the studies in the Cochrane review and exclude them? Yeah.
You know why they?
I actually don't know, and I should have had time. I was gonna look and see which 2 studies they excluded and why. I did not do that. I should have actually done that. That's actually an interesting question.
I wonder if Cochrane used both observational and randomized.
Although I think it's always been done. That part of this that always worries me, especially when you see 7 different meta-analyses with different conclusions, is how objective the criteria are before you know what the result of the study is. It's always worries me.
Yeah, so one of the things is a form of bias that comes about because it's from the people who are doing the test, doing the meta-analysis. And depending on how scientific or critical you're going to get, you strive to avoid that bias. And so one of the things that happens, so if you would imagine you and me doing a meta-analysis on some topic that we knew about, we would have a tendency to look for articles that we already knew about because we already know the literature, we think we do, right? So what you really want to do in an optimal setting is have somebody else do that literature search for you. They have the advantage of having a Cochrane review. But if you were doing this on your own, you would probably optimally want an independent librarian to do this for you. We actually have this kind of service, and we want to have them help craft your search topics and do the search for you instead of you doing it. Because if you do it, you're going to miss things, or you're going to be biased in the way you look at it. And the other, if you do a guideline or something like that, obviously get to the point, sometimes they actually ask an evidence center to do certain reports, so to avoid that unbiased and evidence-based thing. And I agree that if there's Cochrane, articles that were included in Cochrane, not in the medical, you don't want to establish why they weren't being included.
And I guess at least a little bit of reassurance that Cochrane was done right is the person that coined the term evidence-based medicine is the senior author on this paper.
Right, and the fact that they use Cochrane,
Yeah,
I mean, that's going to be an independent search right there. So.
Yeah.
So I just want to add that they actually were able to find 2 studies that met their inclusion criteria that was not in the Cochrane review. So I don't know if the Cochrane missed it or they just did not include it. And that included a study back in 1956 and then a study in 2006 in the Egyptian Journal of Chest. So I just want to add that there are these 2 studies. Cochrane didn't add them, they added them. It was in the time frame that Cochrane had them, or was in the time frame that it might have been included in the Cochrane database, but they excluded. All right, so I guess we talked about 2 main concepts: is search, how it, and we also talked about heterogeneity. Is there anything, I did mention one thing during my slides, I was wondering if there's anything that you guys want to talk about more. Yes, Dr. Glenn.
Well, one of the assessments you should do on an article if you select your analysis is you need to look at them to show some bias as well.
Mm-hmm.
And so you need to look at the author, if you sponsored those trials, things of that sort, because, and you need to do some sort of assessment because one would think that with looking at corticosteroids, for example, that you're probably not going to have a large source of bias introduced, but with different types of medications or treatments, you could well have biased articles. And you need to know that, and it may not be to the point that you exclude them from your meta-analysis, but it's something that you need to mention in your analysis because that will influence your results.
Yeah, so that's something very important that I think every meta-analysis does, is that once you pick the studies, you make sure that the studies itself are not biased. So I think that's something we can talk about. I will appropriately, when I'm talking about bias, I'll appropriately click on Razi's face and it'll take me straight to the bias section. And so again, the questions that you might want to ask, or at least our study asked, was allocation sequence adequately generated, or most importantly, was there appropriate randomization? Second question was the allocation appropriately concealed. Third was, is there knowledge of the allocation intervention, which means basically is there appropriate blinding? And then eventually also ask the question, are the reports study free of suggestion of selective outcomes? So there's an outcome bias, so there are certain outcomes they did not report, which I think is important. So these are the 13 studies that we talked about, and they all went over all these questions that I answered to look at all of them. And what you will find out is actually based on their analysis or their what they thought is only 5 of those 13 studies actually had a low risk of bias. The rest of them had a high risk of bias. Now, having said that, their argument is that, well, these studies that are low risk of bias are actually the larger studies. So actually 70% of the population or the group of patients that are all in the meta-analysis came from studies that are low risk of bias. But obviously we know that even the small studies usually are outliers in terms of the results, and they can skew results significantly. So they did they look for bias every meta-analysis. We should look for bias as well within the studies themselves. And as I mentioned, 5 of them actually are only that they thought was having low risk of bias. Okay. So I think that's very important when you kind of read the results and making a conclusion about your meta-analysis.
So when you see something like this, and you're doing a meta-analysis and you found 5 studies that you think are higher quality than the rest, should you do a sub-analysis of your meta-analysis, limiting it only to those studies that are better done? And this is where you get into you want to believe that question being asked blinded to what the results of those studies are, but I think that would be the question. I mean, to me, I'd want to know that the conclusions that we're drawing from all of the studies is supported when we look only at the studies that we think are done better.
Yeah.
Yeah. Well, and they did do that, right? They have several forest plots where they put in.
I saw it on the length of stay. I didn't see
Yeah.
any
So what? Yeah. So what they did is, you can go back to the results. So they did it on some, but not all. They split. They did subgroup analysis and just included only low bias, like for example, in duration of hospitalization. So I think that they actually what they did is, if you look at the appendix or of the study, they actually did it on all of them. But I think the only one that actually showed a difference between the two was duration, which is why they included it. But they did do it on all. It was just that, when you compare two studies to two studies, they didn't really find a difference in terms of the results, so they didn't really include them.
Annals did a nice job. I think there's a 17-page appendix. It's just full of, of forest
Different
plots.
forest plots.
Yeah, yeah. Can we go back to that table for a moment, though, the one that you had the low bias? And I guess it really,
Yeah.
you can break these high and low, but it's really interesting because there's about 5 or 6 things that go into that bias. But to me, all of those scales have always, they sort of treat, concealment of randomization and sort of, dropout is the same magnitude. You get sort of 1 point for each. And I think from a bias standpoint, some of these things, when we look at allocation, sequence treatment, blinding, attrition, etc., sometimes those are tough. Particularly as tough as there's some treatments that you can't blind. So you get a 0 for that. Does that mean it's a low risk? You just absolutely can't blind some treatments also. So I like an estimate of that. I think it's just important that we always know that it is an estimate. I mean, if I look down for this, particularly if we're starting to make diagnoses on some of the more subjective stuff, not mortality, that's very subjective, but some of the other things, that are, I think randomization then, well, that was there, but, concealment of randomization, blinding for this type of treatment is probably more important. And some of these might be more important for other types of clinical scenarios of treatment.
Any more questions? All right, so we can go back. Again, we talked about our search. We talked about bias. We talked about heterogeneity. Yeah.
Anytime it seems like steroids are, I think on most of us know, are one of those treatments that engender the most heated sort of opinions, both pro and con. And so I would worry a lot about publication bias. That you're gonna do the study, it's gonna be negative, and you're just not gonna publish it because you think A, no one wants to see a negative study, and B, you went in to prove that steroids are going to be good, so you're not really all that excited about publishing a study that shows the opposite. So I would certainly worry about that.
Yeah.
So you're going to talk about size and effect. I mean, I'm not sure that has a lot to do here because the studies are similar. But if you do a meta-analysis and you have one study that has significantly more patients than the other or significantly stronger effect, then that single study can influence the overall meta-analysis. That's the source of concern. The size and effect is important. And looking at your forest plots that could seem to be a problem in this study.
So I think, as Dr. DeJovi mentioned, so something very important as well, meta-analysis, is publication bias. So we can talk a little bit more about that. So it's a very important limitation in systemic reviews. Again, what it means is that basically not all articles that have been published, so it means that you're looking at published data that does not really look into all of the outcomes that you want to look at. And the reason why that happens is sometimes when you have a small, for example, negative study, usually it might not get, or you have a difficult time getting it published, or publishing it in a good journal, so you might have problem finding it. So just because you can't find it in your search doesn't mean it doesn't exist and shouldn't be doesn't matter. And that's kind of where publication bias comes into. When your article in the systemic review basically does not represent the complete set of studies out there in the population. So, and then that's something every meta-analysis should look into. So there's, again, different types. Availability bias, so the study that you want is just, some of them are available, some of them are harder to find. So that's why your search has to be very comprehensive. cost bias. You just don't want to pay the cost for the article to read it. Familiarity bias is something that Dr. mentioned. So when we do our search, we look at articles that we are familiar with, journals that we are more familiar with, and while excluding others. So you might not have, again, a representative study base. And then outcome bias, when you have studies that don't report all the outcomes that they measured and all these things, or they report the good outcomes and they don't report the negative outcomes or the neutral
The
outcomes.
problem is that you have, the studies have negative outcomes don't get published.
Correct.
Studies that have positive outcomes
Get published.
So you always worry about that if you're not seeing negative outcomes.
Correct. Right. So that's something to look into, and there's different ways of doing it. What we our study looked at, and I want to talk about, is something called a funnel plot. And a funnel plot is basically what you have here is you have a group, all these studies. You've got usually your relative risk, odds ratio, hazard ratio, whatever it is, right there in the middle. Left favors interventions, right favors control. You got the precision of the study, and usually good studies with low relative bias and with a high number of patients in the studies get higher precision. And usually the results are not as skewed as smaller studies, so you'll find the results, whether positive or negative, to be closer to your relative risk, odds ratio, hazard ratio, whatever it is. And then you've got your small studies out there, low precision, that can be skew results here or there. And what we should find when you do a funnel plot is you find something even like this. So you've got your good studies, you've got your small studies, and you've got some favor intervention, some favor control. But when you have something right here on your right hand side, you can see that there's a bunch of studies here that you just don't see. And what this tells us is that, again, as Dr. Ulad mentioned, that you might have studies out there that are favors control, or basically are negative studies, maybe a smaller study that you have a hard time publishing. So even though the results are there, it's not published and you can't really find them. And that's something what we call publication bias. And that's another way, and this is another example of the same thing. So you've got your odds ratio here. You got right here in the middle between the kind of the two studies, or the two groups. And then what you usually have is that you have your precise study, your good studies closer to that line, and then you'll have your smaller studies out there, and you'll have some with the positive or negative outcomes. And now if you look at the circles with the open dots, if you remove those, you'll have, again, similar scenario where we have all these negative studies that are that are small, that might not get published, that you might be missing. Or you might have a lot of small studies that are leaning towards one way that might actually skew results. So that's why it's very important to do that. And when I looked at our study, they only had funnel plot for the mortality. So I'm not, maybe because of the number of studies that are out there, they included all the outcomes that we mentioned. So the only thing they mentioned was the mortality. And what you can see is that you see that relative risk, you've got of 1, and then you've got here the line that goes through most of the studies. They'll have more precise studies, and there are some of them on the left and right. So I think they're more appropriate. You have one study here that is really skewed, less precise study, but that's only kind of looking at one funnel plot. So I'm not sure. I mean, looking at it, I can't tell you that they did a good job in looking at publication bias. I know it's only a small number of studies, so it's difficult to do. So I don't know if Dr. you have anything else to comment on that.
No, and you can't draw a funnel if you have a few. You don't have very many dots. You can't see the pattern.
Yeah, so it's really, I can't really say if they did a good job in excluding publication bias when it comes to this.
Well, remember, they can't exclude publication bias. What they're looking for is their sense of publication bias. You can't do the literature search if it's not published. You can't find it. So that's the issue. So you're looking for publication bias. You can't control for it.
All right. Any questions? We'll move on to the next topic. All right.
So, Mohammed, I guess the one piece that's not part of, not a methodological question, the clinical question which I always struggle with is that I guess in my heart I don't believe that we know how to manage inflammation in patients who are infected. And I think that is going to be an underlying resistant to me for these kinds of studies that I don't know how to deal with because it's not methodological, but it will always make me less likely to believe positive results because it seems unlikely that without a marker of, I get that TNF goes down, but that's not always a good thing, right?
Mhm.
And so, given that we don't measure anything, how could we possibly know that we're doing something that makes sense? But I mean, that only lasts so long, right? At some point, you say that the studies are so overwhelming that they overcome that.
Yeah.
I'm just not sure I'm there yet.
Yeah.
That's the part that's hard.
Yeah, and I completely agree with that. I think there's, I guess, one more topic that I wanted to talk about first. I think Dr. Roulette kind of touched on it a little bit about effect size and looking at also the validity of the study. So there's, when I was reading meta-analysis, including this one, they always talk about something called the grade, which they look at the validity of studies. They've seen it multiple times before, and Cochrane uses it all the time in all their studies. So that's kind of something I want to touch on before we kind of end up and wrap up. So again, was the validity of the included studies appraised, and how did they do that? And that's where grade comes in, which is basically an approach looking at an outcome or a study looking at the quality of the evidence and the strength of recommendation. So how do they do that, and what do they look at? First of all, they look at the type of evidence. So randomized usually controlled trials give usually the highest marks. They look at the quality of it, the consistency of the study. So again, if they basically look at the relative risk or whatever confidence ratio, intervals as well, especially if they're very different from one another, and if the studies are consistent with the results, as Dr. Dijon mentioned. Directness, so is the studies that you're looking into actually looking at the population that you want, the medication that you're using, and does it really matter to your question, and of course effect size and precision. So what it is basically a grading system. Randomized controlled trials usually have a highest grade. They start off with a 4, so if it's randomized controlled trials, they get a 4, and then they kind of drop marks based on, again, risk of bias, which we talked about before, consistency, directness, all the things they talked about, precision, and again, publication bias. So, the more an outcome is at risk of these, it drops points, and the validity of the studies actually, or the outcome goes down. And they also give more marks, as Dr. Olet was saying. If there's a large effect size, they actually bump it up a little bit higher. So usually a score of 4 or higher, and usually when you read meta-analysis, we mentioned that. So 4 or higher is a high quality evidence, 3 is moderate, 2 and 1 are usually low or very low. If you're either up to date, they usually just score low or very low as low. And when we look at our study, they looked at all these things I mentioned: consistency, directness, precision, all the outcomes that we talked about, and then they labeled the evidence. Most of them were moderate, some were high, and then some of the only low was the severe neuropsychiatric complications, so we talked about before. And that's something we kind of want to look into when you're looking at the study. Any questions? All right. Okay. So I think we can kind of start wrapping up now. So let's go back to a little bit of a conclusion. So, in conclusion, what are the things that I believe in this meta-analysis? First of all, I think it's a very explicit eligibility criteria. They had a very comprehensive search. They assess the risk of bias, address all the outcomes that are important to me, at least, and important to most people. They applied the grade criteria. They did a rapid analysis, which is what we talked about before, and then they put it as a strength. That even though there were 5 studies, only with low risk of bias, they presented the majority of the patient populations in the meta-analysis. So, in terms of limitations, again, they didn't. Even though there was question specific, they didn't really talk about the duration of steroids, the IV versus oral, dose of steroids, even microbiology etiology. So not all community-acquired pneumonia, I think, is the same. Also, even though it's not part of their exclusion criteria, most of the studies excluded GI bleeds, immunosuppressed patients, and patients with neuropsychiatric adverse effects. So just keep that in mind as well. And the reason why it's very important to know and read meta-analysis is because of this. There's been 2, 3, 4 maybe meta-analysis recently regarding the same topic, and this is the one. The one above is the one that came out in Chest in January of this year. This is a subgroup analysis looking at patients with severe pneumonia. Based on their meta-analysis, there's no difference in mortality. Well, the meta-analysis that I'm talking about tells you that there is a decrease in mortality. The studies were mostly, the time periods were the same, the analysis was the same, but they come up with 2 different results. And you need to know exactly, you need to read the meta-analysis and understand how they came up with the results. And if you actually look into that, they only, for example, the one in Chest, they only included, in terms of severe, only 2 studies actually were what was labeled as severe in our study. So even the study population was a little bit different between both groups. So even, and I'm not sure why I haven't read the Chest article yet, so I'm not sure if the definition of severity of pneumonia might have been different, or how they came up with different studies when they were looking at severe pneumonia. So you just have to keep that in mind, that there's a lot of factors that goes into this. So you might read one meta-analysis, tells you to do something, and another one comes in shortly afterwards, it tells you to do another. So that's why I think it's very important to look at this. And then I think, what's next after this? What I believe is that I think there is a role for steroids in community-acquired pneumonia. I just don't know who, when, or where. And I don't think any of the meta-analysis kind of answers those questions very well. And I think what's next is this. There's a study that's coming, or actually ongoing right now. It's called the Extend Steroids. It's financed by the VA, and it's basically it's a randomized controlled trials looking to patients with severe pneumonia only, and they are double-blinded as well. And they have patients with patients on steroids, methylprednisone. I'm not sure what the dose is, but for 7 days, and then taper over 11 days versus placebo, and then look at all the outcomes that I just basically mentioned. So I think we'll get more information. Again, as I mentioned, I think there is a role for steroids, and I believe that there is a role for steroids in pneumonia. I just don't know who, duration, dose, and who to give it to yet. And I don't think we have that great evidence to tell us otherwise. Any questions?
Can I ask a question? So I'm a hospitalist, so I'm in a room with experts in pulmonary medicine and pneumonia and sepsis. What am I supposed to do with my community-acquired pneumonia patient that I get down on F1 in a couple of weeks?
Yeah, so
I think it's a good question. It becomes an easier question if, like many of our patients, they have comorbidities that would merit being treated with steroids.
Yeah.
And so I think one of the questions, I'm going to avoid answering your question.
I noticed that.
Yeah, but one of the things that we see often is, I have this patient with COPD who has pneumonia. Should we avoid steroids in this patient because I'm worried about making their infection worse? We had a patient the other day who there was a question of vasculitis. Should we avoid steroids because we think pneumonia is individual? And I think so one of the elements of the answer is that in those patients, and we see a lot of complicated patients who have that question, I think this tells me we don't need to worry about giving them steroids. We should give them steroids because they may actually get better from pneumonia. Right? I think this data is intriguing. We know, for example, with people with terrible tuberculosis, they can get better if you use steroids adjunctively. We all know that if somebody's got pneumocystis pneumonia, we should be giving steroids. And those kinds of data are compelling to me and make me wonder if in the future we're going to be doing this. I think that it might make us wonder in those with severe pneumonia if we shouldn't do that. The persons who have mild community-acquired pneumonia, I think we don't need to worry about that. So I think it's the severe cases, and you have to wonder if you've got a severe case and it's 11 o'clock tonight on October 14th and the person might go to the ICU, I think you might err on the side of the steroids.
yes, Dr.